Welcome back, guys. We are just about to start our next hour. A dear friend of mine from India who's been with me for a very long time with all of our Parekh Family Foundation efforts in India will be moderating. Mandeep Dhillon is going to be taking us through Midfoot Injuries. This session is sponsored by Paragon 28. Mandeep, it's all yours.
Thank you, Selene, and it's always nice to interact with the Parekh Family Foundation because of the great academic things you guys do. And I'm so glad that the faculty which we have, we've got 2 international and 2 guys from India. And I'll start by asking them to say something about them. So I am from Chandigarh, the Postgraduate Institute of Medical Education and Research in Chandigarh. I'm the chief there. I'll ask Khairul from Malaysia, Jiten Mangwani from the UK, Balwinder Rana from North New Delhi, India, and Sampat from Pune in the center of India to say a couple of things about themselves. Let's start with Khairul from Malaysia. Khairul.
Hi there. I'm Khairul Faizi Mohammed out of Kuala Lumpur. It's nice to be here. Thank you very much for this opportunity, and hope we can share a bit of information with each other. Thank you.
Jiten.
Yeah, Jiten Mangwani. I'm in Leicester, UK. Trained initially in India. I'm currently chairman of the scientific committee of the British Orthopedic Foot and Ankle Society. Just looking forward to the session and learning from each other.
Thank you. Balwinder, you have to switch on your mic.
Hello, I'm Balwinder. I work as a foot and ankle surgeon in Max Group of Hospitals, New Delhi and Gurgaon. And thank you for giving me the opportunity to be here, Selene and Dr. Mandeep. Thank you very much.
Thank you. And Sampat?
Hello, I am Sampat Dhumbre Patil from Pune. I am director of department at Pune Sahyadri Hospital. Thank you.
Okay, guys. So I'm going to be sharing my screen, and what we have for you is a compilation of cases of midfoot injuries. We've not kept them too complex because we don't know what is the level of people who have joined us, and we've kept the trauma of the midfoot so that we are able to tell you the principles involved. And most of these cases have been, given to us by each of the faculty members. So we will share our experience. I'm going to start sharing my screen, folks, if you allow me. What happened? Just a minute. Just give me a minute to see what happened to my...
On the bottom, if you hit just share screen.
Yeah, I know. I have to open my PowerPoint first before I do the share screen. Yeah, now I've got it, because then the PowerPoint comes up. Okay, so for those of us who are there, that's us. And we've got the host is Selene, and we've got a great faculty who are focusing on their work on foot and ankle. And today I'm going to be talking about midfoot injuries. And what we are going to discuss with you are cases between the area between proximal to the metatarsals and distal to the calcaneus. So that's the show parts and Lisfranc joints. And let's see how many cases we go through in the next 58 minutes or so. Now, we'll start with medial column injuries, and out of this, navicular is the commonest isolated medial column injuries. I'm not talking about complex dislocations, but isolated medial column injuries. And we'll start with a case given to me by Dr. Khairul Mohammed. This was a 25-year-old male who was a contractor who fell from a height of 10 feet, and the foot was in a plantar flex position. So it's a hyperplantar flexion injury. And he came with a swollen foot and dorsal bruising. And if you can look at these x-rays, you can see that there is a gap, something missing between the cuneiform and the distal end of the talus. And you can see the comminution and the distal end squeezed out, which the dorsal surface of dorsal piece of the navicular has gone upwards and out. So there are certain points which we should take note of. One is the medial column in relation to the lateral column becomes shortened. There is comminution, which is most often inferiorly and laterally. And there is dorsal displacement of the main fragment. This happens because of the hyperflexion injury. And in this particular case, since there is no calcaneocuboid joint disruption. This doesn't come as a midfoot or a chopard joint injury, although if there was something on the lateral side, it would be classified as such. And there are no fractures on this side. So, should you get a CT scan? What about Balwinder and Jiten? Would you like to get a CT scan for this case?
Yes, for sure. I would want to get a CT scan because I want to see all the fragments and the extent of comminution in the navicular itself. So the X-ray will not tell us how bad the navicular fracture. It looks like pretty bad. The plantar surface seems crushed. And subtle injuries on the lateral column might be missed on a plain X-ray. So I would want to definitely do a CT scan to see these things.
Jiten, what's your protocol in the UK? Would you get a simple CT scan or a 3D CT scan?
So this gets a CT scan through our ED and will be reformatted into a 3D sort of reformation. I think the key here is the soft tissue as well as any of the imaging. So for me, soft tissue is of prime importance when the patient's coming through. So the amount of soft tissue damage will determine the outcome to a certain degree, not just the bony injury to it. And with that kind of fracture, as Balwinder said, we have to be really, really looking carefully on the lateral column to see we're not going to miss out on something that wasn't apparent on the index radiographs.
Okay, thank you. Thank you for your comments. And let's say you got a CT scan, and maybe I won't show it to you. Sampat, what would you plan to do?
Now, first thing, as we discussed, isolated medial column injuries will be there. So on CT scan, I will evaluate lateral column still because there can be still occult injuries. So CT scan, I will rule out first lateral column injuries, and then we'll look at the medial column. How much is the amount of comminution, and shall we go for the fixation of navicular alone?
Okay. So let's see what Dr. Khairul did here, and then we'll see what about the comments. Now, what he did was, let's say from a point of view of CT scan, there is no lateral column injury. We'll take that as a given. And yes, we would like to add the pictures of a CT scan. So with the shortened medial column, what Dr. Khairul did was he used an external fixator to distract the medial column to open up the joints over there, get the length of the medial column, disimpacted the fracture, and tried to do it with least soft tissue damage. Since there was comminution laterally and inferiorly, he used a dorsolateral approach. Khairul, would you like to comment why you used a dorsolateral approach?
Well, this was done because that was the area where there was a lot of comminution, so I can actually control to see if I can actually fix the articular surface to conform to the shape of the talar head.
Mm-hmm. So that's a very key point. I think we'll come to that later on. And then he did a reduction and temporary fixation. Would you like to go through the steps which you did for the reduction and temporary fixation?
Yeah, sure. I think the main thing out of all of this is to try and fix the articular surface, number one, that to follow or conform to the shape of the talar head. In a lot of cases, there will be a sort of constant fragment at the plantar lateral aspect of the navicular. Now, the question about all of this is whether that fragment, that sort of constant fragment, is actually large enough to be fixed or not. So that will determine whether we have stability of the fragment from actually displacing dorsally. So when we're fixing all of this, we would like, just like in the calcaneum, we would like to fix all these fragments towards that plantar lateral fragment of the articular surface first, and once we have got the articular surface on the talar navicular side, then we try to fix everything else to that particular area. And in certain instances, it may be difficult to actually hold everything together. So some of these K wires may need to traverse to surrounding bones as well to help, to help add in terms of temporary stability.
So that's a lot of K wires you've used. Anyway,
It is,
it
yes.
seems we have gotten the key issue of the talonavicular joint reconstructed. And then you added some small mini fragment screws and plates, and some of the K-wires were bridged. But I noticed that you added a small T-plate on the dorsal surface. Could you
Yes,
tell
that's
us
right.
why?
Yeah, that was because after we remove some of these K wires, we actually found out that the dorsal piece which was squeezed out is still subluxed superiorly. And that's because the constant fragment, we could not actually purchase the constant fragment on the plantar lateral aspect good enough because it was really very small. So we used this small T plate on the dorsum to actually help bridge and push the fragment down, and to actually help fix it to the rest of the fragments.
Okay, that's what you did. And Jiten, any comments from you?
Yeah, so it's a very difficult injury to get it right in terms of fixation. And Khairul, hats off to you. Looking at the articular surface, you managed to get the articular surface pretty congruent there, and the joint reduced. The only thing I would probably do slightly different is I would have bridged between the talus and cuneiform, because there will be that sort of tendency for that to sublux dorsally. So I don't know what the outcome was eventually, but I think I would have sort of gone from talus to the cuneiform to bridge, and then remove that implant hardware about 3 months down the line.
Yeah, agreed.
Sampat or Balwinder, any comments before we see for any take-home messages?
Yeah, I agree, sir. I mean, that talonavicular alignment itself is key. So no harm in at least crossing one K wire to stabilize that particular joint.
Okay.
So okay. So in
Yes,
civil
Balwinder,
community,
please go ahead.
Any role for a primary fusion if it was not reconstructible? It looked like a bad injury. Would
That's the
anybody
next case, Balwinder. We'll be talking about
sure.
that.
Sure. Okay.
Okay. So I think Khairul's got this take-home message for all of us. We must remember that the navicular reconstruction is difficult. First. Second, the small fragments need to be put together like a jigsaw puzzle. And you must use distraction. That's the key point here, which all budding ankle surgeons have to understand. Don't hesitate to use distraction, because you need to see the talonavicular joint, which is a round surface. And I personally, in my experience, I really can't overcompress it, because then I would get an incongruent talonavicular joint, which is important for us. And as in this case, the approach is based on the area of comminution. And the bridge plates help stabilization. They keep the small fragments reduced. So that's what the message we've got for this. And taking you to a similar case of this is what the this many studies show that unless you can see the distal surface of the talus and the proximal surface of the navicular, you may not get a good anatomic reconstruction. I think we all agree with that. Is that correct?
Agreed.
Okay, now I'm going to show you a case by Jiten Mangwani. It's a sort of a similar fracture, but this came to them late. And this is fairly common if there's not too much squeezing out and there is not too much problems with the comminution. The emergency room people miss it and they come to the orthopedic surgeon a little late. So he was initially managed conservatively in plaster. And that's the CT scan. That shows a non-union along with the navicular cuneiform degeneration. Any comments on what you were thinking, Jiten, at this time?
Yeah, this guy had presented pretty late to me with ongoing midfoot pain and discomfort, and the degenerative changes are established there by that time. So, the die is cast, and what Balwinder was asking for the previous one, which was a very valid question, even in acute setting, particularly for medial column, you keep thinking, should I be doing one operation here, fusing the medial column, whether it's navicular or sort of talonavicular joint, or even beyond? We'll come to that hopefully in the TMT area. So here, the non-union is established as well as degenerative changes are established.
Okay, thank you. And so the question is, exactly, if you were to choose, because everybody wants to salvage the bone, the problem with the navicular is it's got a poor blood supply, number one. Number two, that makes it difficult for it to heal. So if you have to salvage it and you want to sort of fuse the joints, which joint would you fuse? Would you readily fuse the talonavicular, or would you sacrifice the navicular-cuneiform?
So I think if you can spare talonavicular, we all know there's, the short part joints are crucial for movement in the foot and stability and the gait pattern. So if you can spare talonavicular, you would like to spare talonavicular.
That seems like a good solution. So this is what Jiten did. He actually saved the talonavicular, but reconstructed the navicular along with the cuneiform into one kind of bone block. And at 12 months follow-up, there's good function, no midfoot pain, and the metal work remains in situ. Any comments on this, Sampat?
Agreed, sir. I mean, here the talonavicular joint is vital, and salvaging talonavicular joint was a key point. Unlike TMT joint, here the talonavicular joint on the medial side is much mobile. So preserving this is really worth.
I think one of the key points which we are not sort of highlighting so much is the fact that we need to add vascularity. So maybe by fusing this, you could get vascularity. What do you say to this, Balwinder?
Sir, sorry, I missed the audio in there. Can you
The
repeat?
key point is that you need to add vascularity to the healing navicular. And by fusing it to the cuneiform, you add the vascularity. So what do you say to this?
Yes, I agree. It's a problem in navicular, and giving extra bone attachment distally, fusing it will bring in more blood vessels from the navicular side. And I've seen that in subtalar fusions, in avascular necrosis of the body of the talus. Sometimes you can vascularize the talus, and I have a couple of cases now where a subtalar fusion salvages the talus. So I would say that similar principle would apply here.
Okay, great. Now, both Khairul and Jiten, would you give us an out? Because we have people of different scales joining us today. They're not necessarily all dedicated foot and ankle surgeons. What would be your post-operative protocol in fractures of the navicular in sense of how long would you immobilize? Would you give them arc support? What all would you do for the 1 year after surgery? Khairul.
Well, I think in the immediate postoperative regime is wound healing. That's number one. Soft tissue control, immobilizing the foot for at least 6 to 8 weeks to see whether there's good union or not. And then after that, I would probably walk them with an arch support or a boot with an arch support for at least a period till 3 months until there's good union. And then it depends. And again, if we're bridging or if we're spanning the fracture, then we need to consider removing these sort of spanning either external fixators or internal external fixators at a period of 3 months to allow that sort of to preserve the sort of talonavicular sort of movement.
Is that your protocol, Jiten?
Yeah, so I think certainly pretty much in the same line as Khairul was saying, about 6 weeks of non-weight bearing. But I am more for starting movement early. So even if I keep my patients non-weight bearing for this sort of situation, I would get them out of plaster around 3 to 4 weeks once I'm happy with the soft tissue healing to at least start their ankle movement, the rest of the foot movement. And then they keep non-weight bearing for 6 to 8 weeks and then go on to weight bearing in a boot for about 3 months in total.
Thank you very much.
Beyond that, I think the key is to watch it like a hawk as well, and do a CT scan later on, particularly in fusion surgery, because on plain radiographs you can never be sure whether you've achieved adequate bony union for them to be stable and be walking on it.
Okay, that's a fair answer. So the take-home message, I think, from these cases is we've got to save the talonavicular joint if we can. And if you want to sacrifice the less essential joint because it improves stability and vascularity. Okay, so we'll go on to lateral column injuries now because we've got about only 40 minutes left. So lateral column injuries actually, I think, have many more problems because you often underestimate cuboid fractures. Anterior end of calcaneus fractures are misdiagnosed, and column shortening leads to a very severe abduction foot deformity. So I'm going to show you a case which was seen by us with complications. This was initially diagnosed as cuboid fracture. Now, Sampat, would you like to comment on this X-ray? What would you do if this case X-ray was shown to you?
Yeah, agreed, sir. So looks like a lateral column injury, and cuboid looks united with short.
Oh, it's a fresh case.
Okay, so definitely there is a lateral column injury, a cuboid fracture there, but need to see other column as well. So need to explore for the other injuries as well with CT scan.
That's the other X-ray, and he had no AP view at that time, but he was put in a POP cast. Now, would you agree with me if I say this is criminal? Anybody?
Yeah.
We see that so often, missed injuries. Yeah.
And when he came to us at 8 weeks, this is what the foot happened.
Ooh.
It's collapsed into valgus. And this is just an example of trying to show you what happens to this foot. This is just an initiation of mine to show you what can happen to the foot. He's got a whole valgus foot, painful gait, and he's just come to us recently in the last 2 weeks. We've not treated it, but this is just an example to show what can go wrong if you don't understand the columnar concept of the midfoot. Anyway, so we won't discuss too much on this, because if you go into the how you would treat this, we can't show you any X-rays because we haven't treated it, but we'll go on to what could have been done. Anybody has a quick answer to what could have been done to prevent this? Jiten?
Yeah, I think initial diagnosis and management is the key with these. And as you rightly pointed out and shown in that radiograph, just one view or one radiograph is not going to be enough to look at the entire foot. So having the whole series of radiographs, if you're relying on radiographs, more than that, I think it's the clinical diagnosis, the mechanism of injury, the soft tissues at the time give away a lot. So, if you're somebody who's starting out your career, I would strongly advise not to rely on anything that's imaging, just to rely on history and clinical exam for these. I think one of the other things, as you've shown in there's a nice paper from the Sheffield group on cuboid fractures in 2016, I think, in the BJJ. And they've classified these into sort of five types of cuboid fractures associated with other injuries or not associated with other injuries in the foot. And this is a classic example of the one that has gone through the intermetatarsal and short part joints, and then be part of the cuboid injury. So I would certainly sort of recommend that as a read.
Yeah. So this case is just as a reminder of what not to do, but we'll come to this case. This was seen by me about almost 10 years ago. She was a school teacher, and she was sitting on a motorcycle, and with the foot sort of protruding outside, somebody hit her on the medial side. She got a swollen foot. She put in a crepe bandage, and she couldn't walk for 3 weeks. And she came to us at this stage with this little crushing of the anterior end of the calcaneus. And this is actually an unstable midfoot, because you can see even only on the lateral view, I'm not even going to talk about the AP view, that there is a subluxation of the talonavicular joint. And this makes it for a complex instability, as Jiten has just told you, that there is a complex instability. And for lack of time, and because we want to go through more cases, I'm going to tell you what we did next. Now, at that time in India, we didn't have too many sophisticated plates, but we used an indigenous external fixator to distract the lateral column. And you can see here in the video that we were able to put the calcaneocuboid joint together, and that left us a big hole in the front of the calcaneus. So we distracted it, and then we fixed that with a big chunk of tricortical bone graft from the iliac crest, and put in K-wires in an X-fix. And since there was a small wound over there, we were very uncomfortable about using a plate. And we had little experience with plates about 10, 11 years ago. So what we did was we put multiple K-wires and we did an external fixator to hold it in place as a distraction injury. Note, we did not do anything to stabilize the medial column. So, Khairul, what could have been done differently?
Yeah, I think from the initial X-rays we can see this is an injury that's traversed both medial and lateral column. So this is one of these sort of transcalcaneal, either transnavicular or talonavicular extensions. So it will be unstable both medial and lateral. So probably during the initial surgery, if we were to put an external fixator both on the medial and lateral column, then we can actually assess the stability of both columns. I think that would be the first thing. I like the idea of putting in the bone block to actually regain the length of the lateral column. And when we're distracting the lateral column, we can see how unstable the medial column is, and that will be a good reference to things. If it's purely soft tissue on the medial column, then we can probably we'll see how unstable that is once we've got the length of the lateral column. But if it's bony as well on the lateral column, then we'll need to address that.
Sampat, what are your thoughts on this?
Agreed, sir. Distract both the columns first, achieve length, and then would have preferred nowadays plate for fixation. And
okay.
Yeah.
Same enough. Okay. Now this is what happened. So we've maintained the column length, and there's a hidden sort of K-wire over there. The graft seems to have incorporated, and she's got good function and a good outcome. She's gone back to teaching. But what I'm trying to say here is not that this is the way to do it, but the principle which we have to do, which both Khairul as well as Sampat are saying, is that we have to maintain not only lateral column length, but make sure medial column length also is maintained. We have to maintain column stability. And now, 15 years down the line, I would probably have put in a plate. You could put in those long plates. And remember, don't only look at the one column which is fractured. There could be soft tissue instability in both the columns, which we have to address as we go along. Let's look at complex. Yeah, please. Yes.
So we also had a subtalar dislocation in this patient. It was a complete.
Yes. Yeah.
So we could reduce that on table and stabilize it because it was subtalar dislocation and middle the talonavicular and calcaneal cuboid. So how would you have proceeded for this? You would reduce the subtalar closed and do the middle column. Yeah.
And what we usually do nowadays, I mean, it's a simple way. We put two traversing K-wires from the calcaneus to the talus to reduce it. And the principle of me working on multi-columnar things is like building a house. You built it from proximal to distal. First, get the proximal joints in place and get the rest of the foot and the columns back onto the reconstructed proximal joint.
Okay.
Okay, let's get to bi-columnar injuries. This is the case by Sampat, there was a young male with road traffic accident, and there was an injury to the dorsalis pedis and a rupture of the extensor hallucis, treated with ligation of the artery and repair of the EHL, and the midfoot injury was missed, and he presented to him 1 month after injury. And this is the X-rays. And Sampat, could you say something here about this X-ray? What was the condition of the patient?
Yes, sir. So he came to us 1 month later, and initial surgeon missed it because of dramatic presentation of bleeding and all those things. So they did repair of artery, EHL, but then the midfoot injury was missed, and they thought it is subtle injury. But I could not see navicular at all. I thought whether we have missed the navicular out of wound because there was a wound on dorsum. So we were really not sure of what kind of bony injury it was there.
This was the CT scan, but I mean, I'll just skip it and show you the wound which Sampat is talking about, a transverse wound on the dorsum, Sampat.
Yes, and in CT scan, let me tell you that the navicular was absolutely sitting below the talar head. So we could find out navicular. It was absolutely plantar to talar head and even more proximal to talar head.
Okay, thank you. Okay, guys, anybody is going to volunteer? We know what Sampat did, but anybody who wants to volunteer, Balwinder or Jiten, what would you do? If you notice, there is a complex injury right throughout the midfoot. It's not really a Lisfranc, it's proximal to that, but we've got a Jones fracture, you've got crushing, we've got extrusion of the navicular. So what would be your plan, Balwinder?
So I think at this stage, with this wound at 1 month, this patient will obviously, my opinion, would go for a fusion of the affected joints. But at this stage, it might not be advisable because there's an open active wound on the dorsal surface. So at 1 month with that wound in this X-ray, which is going for a fusion, I would want to temporize it. Maybe at this stage also, I'll take him to the theater, clean the wound, debride whatever is there, and maybe try and distract it with fixator and see how much reduction. It may be very difficult to do at this stage, at 1 month, but whatever can be achieved can be tried at this stage. And if the navicular dislocated can somehow be brought back closed or by percutaneous joysticking, I would attempt that. Once the wound has stabilized and healed completely without infection, I would plan for a second stage where we want to fuse the talonavicular. I mean, obviously, depending on the navicular cuneiform also, depending on which joints have been comminuted and affected. So
Okay.
that would be my plan, yeah.
Let's see what Khairul would think. Khairul, do you agree with Balwinder, or let's go and see what Sampat did?
Sure. Yeah, I agree with the external fixator. I'll apply the external fixator and try to distract the medial column, and then after that probably get a CT scan to see what the whole picture is like, and then take it from there.
Okay, so let's see what which Sampat did. He made a sort of a special incision, sort of going from the ends of the wound up and down so that he could expose it. He used this, we have local indigenous distractors, we call them JES fixators for those who don't know about it in the international world, but they're cheap and you can open up. I mean, probably you could also use Hintermann retractors for the same procedure. And then, Sampat, would you tell us how you did this stage reduction?
Yes, sir. So actually, that Z incision was there because after reduction, I was knowing that we are going to achieve length. So we increase the wound in Z fashion and use this distal radius fixator for distraction. But what was the key for reduction was Hohmann's, that is forearm spike, Hohmann's retractor, because we inserted the Hohmann's, yeah, that is it. We inserted Hohmann's first along the talus, then reversed it, and then levered it again. In midfoot, I like this trick because Hohmann's is really a traumatic. First, go along the head of talus, reverse it so that you can lever it up again. That will save your cartilage on the talar head as well as navicular, and that really helped me to get back the navicular into place because it was really plantar and this is it. So first go the other way, reverse it, and then lever it up again. That was a trick of reductions.
And you fixed it with K-wires alone. That's
Yes.
the only joint you stabilized. You didn't do anything for the other thing. Do you think the lateral column is okay with this, Sampat?
I mean, sir, after reduction, it achieved so much of length and medial column was so tight and it was lengthened that, and with the wound status, I never thought that I will put anything else there. And it was so stable after inserting K-wires that considering soft tissues and gain in length, I never dared to put on some internal fixation there. And I fixed only medial column, thinking that everything, because even lateral column achieved length, anatomy was good. So I avoided any intervention that side, thinking that it may be done in second stage.
So this is the serial follow-up which he had, and that was the initial post-op X-ray with the wound never really broke down. And that's what happened over time. How long did you keep the K-wires for?
We kept K-wires for 6 weeks and removed it after 6 weeks.
And any supportive cast or a boot, or what did you do for him?
Yeah, we kept the slab because even his ankle was little having a fibula fracture. So it was kept for 6 weeks and then mobilized after 6 weeks with a walker boot.
Okay. That's what happened over time. And at 4 years, he seems to have a decently sort of reformatted foot with a little bit of, I suspect, talonavicular arthritis already setting in. But anyway, we got his foot function over time. Not doing badly. Okay. So what's the take-home message for this, Sampat, and what would you, and maybe then Jiten and Balwinder can give their comments.
Yeah, I mean, midfoot injuries all across the world, they are either missed or misdiagnosed. Sometimes they are distracted by some wounds over underlying midfoot injuries are missed. So let us diagnose them correctly. And once missed, they are quite morbid to treat. That is what I wanted to show, because then gaining length, putting them back is issue. And sometimes these people tolerate arthritis for even longer time. I mean, sometimes primary fusion may not be easy in these situations, although we know that he may land up in talonavicular fusion, but our people, at least, they tolerate arthritis even for significant amount of time.
Balwinder, your comment, and then Jiten before we go on to the next case.
Well, yes, as Dr. Sampat has said, a significant amount of arthritis has been tolerated, and I believe that I would have possibly not given that incision in the first time. That's my opinion, but obviously he's shown a very good result. So I would have tried and get the wound healing before doing anything. But with a K-wire fixation and getting that result, I think it is commendable. But we must be prepared to do to let the wounds heal initially, and then maybe later stage do a fusion. That would be what I would have done.
Jiten, something
Yeah,
from your
so I think it's certainly wouldn't have happened in my hands or in our unit here. But again, great result from what you've done, Sampat. I would have gone in slightly different with this a month down the line. Certainly distracted the medial column. Try to get the navicular back in where it should be, maintain the length on both columns by providing external fixation, let the soft tissue settle down completely, be confident of infection, and I would have come back and probably fused that medial column in one go with plating and bone grafting. So that's what I would have done. But yeah, it's different to see the other side, the other side of management sometimes. Slightly different concepts.
That's okay. Different strokes for different folks. Let's see how it works. But we are just talking principles, and the principles are we must look at all the columns together. Now we'll go on to the next case, which is from Balwinder. This was a triathlon athlete, I think, Balwinder. Is that correct? He twisted his foot and fell, came to you with pain, inability to walk, and a lot of swelling on the foot, and these are his radiographs. Any comments about any investigations which we should order? Because on radiographs, the fracture seems fairly fine. How much was the swelling, Balwinder?
It was a significant amount of swelling, and he had this injury when he was landing from a paratrooping episode, and that I didn't mention it. So he had a significant amount of injury with this X-ray, and actually Dr. Sampat would remember it. He was somewhere in Pune, and he was somewhere in the north, and one of his friends was operated by Sampat, but this guy lived in Delhi, so Sampat referred him to me. So this is that patient who had and the first question that he asked me when I saw him was that will he be able to do Ironman? So after the injury, so that was the question. Yes.
So he is a high-end athlete with a severe midfoot trauma. And that's what his CT scan looks like. Would you like to comment on the CT scan, Balwinder?
Yeah, so you can see there is a significant amount of comminution on the second on the second base. I mean, I'm not sure this is the same patient, sir.
Oh, okay.
I think-
Then maybe
I
I've
think
got
it
it wrong. I've got it wrong. Then forget about it. Now,
Yeah.
what next?
So
You
I
sent
did-
me few CTs. It's my fault that I may have mixed up your CT scans.
Yes, I think it's mixed up. So I did have a CT scan for this. So what we found on the CT that he had a dislocated base of the second dorsally with a fracture, and comminuted base of the second, and a dislocated base of the third also. So the injury was much more severe than the X-rays tell you. So the CT actually defined that was a pretty bad injury, and you could see it in the surgically or in the per-operative pictures that maybe we have next, that the CT was showing much more injury. So the can we go to the per-operative? So that is the distracted. We did a dual incision. That is the distracted second TMT. So you can see in the center the flap of the articular cartilage that is out there in the center of the joint. If you see the bottom right picture, that is the third base dislocated from the TMT, third TMT joint. But this was quite seemed reconstructible because the third was a big chunk coming out with a single line into the articular surface. So we thought the third base metatarsal third base was reconstructible, but the second TMT was showing a significant amount of articular comminution on the plantar side, and a flap of cartilage was already there. So that was the picture on exploration, and correlating it with the CT, we found the same thing that the CT was telling. So the second base, the second metatarsal base was severely damaged, but the third was dislocated, but the articular surface was still okay.
So this is what you did.
Yes. So we found that the first TMT was unstable. There was no fracture. There was a plantar chip on the first TMT, a capsular avulsion or a ligamentous avulsion, which was seen on the CT. And once we explored the area, we found that this first TMT was easily subluxatable. So it was pretty unstable. So we just did a joint spanning fixation for first TMT. We found that the second base, the second metatarsal base, was not reconstructible. It was severe articular comminution. So I did a primary fusion for the second. And the third was one single line into the articular surface of the third metatarsal base with a dorsal dislocation of the major fragment. So we did a open reduction and did a joint spanning fixation for that. And a cable fixation for the lateral column.
What
Yes,
made you change from putting the conventional, and maybe we could get in Khairul to give a comment over here. Conventionally, we used to stabilize the first tray with multiple screws. What made you change from multiple screws to these bridging or spanning plates?
We did not want to violate the articular surface. Was very nice, very fine. So there was just a big fragment from the plantar side. It was not like intra-articular. It was an avulsion fracture, which was making the joint unstable. And otherwise, the articular surfaces was pretty well. So I was not fusing it. So I just thought about bridging it without violating the articular surface with a big drill bit and the screw going through it.
So that's what it looks like. And what's your post-operative protocol after you sort of fix them with plates?
So I put him in a splint for a couple of weeks. And then I asked him to mobilize his ankle and subtalar joints, but without putting any weight. So he was in a removable boot at that time, exercising the ankles religiously. And I saw him about 2 weeks ago. That was 4.5 months down the line, and he could jog out of my in the corridor out of my OPD room. And in my room he jumped at least a couple of feet high, standing from his position. So he's a motivated guy, which is unusual. Obviously, when he asked me the question, will I be able to do an Ironman? I denied. I said, you have to forget. It is a career-ending injury for you as an athlete. But this guy was motivated, and he did what I was least expecting when I saw him last.
So would you leave the implants or would you take him out? Jiten, we'll go to a case after this. But Jiten, what would you make a comment about?
I mean, this case highlights a lot of principles there. If I can just sort of come to those. One is obviously around initial imaging is important, particularly CT, to delineate other injuries that you won't be able to see on plain radiographs, which which Balwinder has covered. It also highlights that the first TMT instability, particularly on table. So my routine when I take these patients to theatres when they're ready for an op are to do an on-table screening, because that gives you a lot more than a CT does, or a combined CT and X-ray does. So if you look at AB ducting the first ray and you suddenly see a lot of incongruity and opening up of the joint, you're dealing with first TMT instability, and which is what Balwinder sort of has tried to address here. Also sort of aligning the second metatarsal in line with the intermediate cuneiform is the key to get the keystone back in there. And the other thing here is to be mindful that when you are actually doing the first TMT fixation, be mindful of your soft tissue, where you're going to be, soft tissue envelope, where you're going to be putting so much implant into, because what you don't want is your X-rays looking amazing and you've got wound breakdown on top of an initial soft tissue insult that foot has had with a significant injury. So I think this case highlights a lot of good points for me. And yeah, it's a job well done. And with regards to your question for your transarticular screw or putting a bridging plate, obviously there's been a change in practice in the last decade, particularly towards using bridging plates rather than transarticular screws. And we published that last year, looking at a systematic review on this. And although there's no hard science behind it yet, but there is obviously a trend for outcomes to be better in bridging plates. And you've got the option of coming back and removing some of the implant to allow some of those joints to be more flexible.
Yes, thank you. Okay, so this is a case from Jiten. This is your case, Jiten, which you sent me today morning. Would you give us some history about this footballer of 25-year-old footballer?
Yeah, so this guy plays the county level football, and he's not a professional footballer, but he was unfortunate to get involved in an RTA, 25-year-old. Again, you can see, frank sort of TMT dislocations there. And foot swelled up like a balloon initially, gradually swelling settled down, wrist and soft tissue resuscitation happened. So if you've got the CT, Mandeep.
Yes.
Yeah, and it also sort of highlights that there is incongruence of the lateral column as well as the medial column injury here. So it's through and through essentially. And on the first TMT, there's a hint that there is something going on. And this is the point I was trying to raise in the previous case, Balwinder's case as well. You really have to test the first TMT on table with this kind of injury, because it would have sprung back sometimes in the position, and in a non-dynamic CT, you're not going to be able to pick that one up.
Good point. Okay, so that's a very good point. I think we should put across over there. So this is what you did. So any comments on what you did? You have something like a home run screw there. Is that correct?
Yeah, so here it was a bit of a, trying to get the soft tissue envelope to take the adequate fixation rather than getting too bogged down and putting 2 or 3 or 4 plates, whatever we want to. So I think one has to be pragmatic. The idea is to keep the medial column as stable as you can, put your keystone back in and stabilize the lateral column enough so that you can allow for rehab early enough, i.e. 6 weeks, 8 weeks. So here I've stabilized the first TMT, as you can see, with a bridge plate. With a screw from the medial cuneiform to the second base, it's essentially creating a Lisfranc equivalent. And it's a fully threaded screw, as you can see. So you're not compressing it, you're just using it as a positional screw. It then allows your second incision to be slightly more lateral, so that the third TMT is stabilized through a bridging plate. And once you've stabilized third TMT, I tend to then again screen the lateral column. I don't necessarily, I used to put KYs routinely to stabilize the lateral column. You don't, because most of the times the dorsal ligaments is enough to to bridge across to the fourth and fifth. And once you stabilize middle and medial column, your lateral column a lot of the times becomes stable anyway, and you're going to put them in an immobilization and non-weight bearing for a period of time. So why risk putting another wire and hold it in position?
Fair enough. That seems to be a fair message to go across. Any other comment on this?
Yeah, Jit, what was your sequence in terms of doing this?
So the sequence here is initially obviously on table EUA. Once I'm going to do the medial side, I put my medial incision, the dorsal medial, so that it creates enough bridge between the medial or the dorsal medial and the longitudinal incision, which is going to be dorsal. And I would certainly stabilize, because if you can see that screw is cannulated. So I tend to put a wire from the medial cuneiform to the base of the second, get that reduced. Obviously open reduce it. With this sort of injury, you have to open reduce your Lisfranc area, open reduce and stabilize that, and put the bridge on the third afterwards.
Yeah, I think that's a good point, because it's very important to understand that when you're putting a lot of these sort of hardware on the medial column, there's going to be a lot of potential interference between all these screws and all the trajectories. So you really need to plan which one goes first, and then how you're going to stabilize the first tarsal joint, like you did using an X plate on the medial aspect. And if for some who are actually going to do some cross K wires from proximal to medial, then we need to avoid, the sort of home run screw or a fiber tape if somebody's going to use that.
That's a good point there. Okay, so but I don't think the story ended there, Jeet. That's 6 weeks post-op, well reduced, stable construct. Yeah, go on, please. Go on talking.
Yeah, so he was doing well, 6 weeks post-op. It was well reduced, stable construct, and he at this point these radiographs are obviously non-weight bearing, but he goes on, I think if I remember correctly, to start doing what he loves to do. So essentially, goes back to play sports, and I think he's broken his metalwork eventually. So I've had a conversation with him in the post-op period, which I do with all of my patients, to give them the option of whether they want or don't want their metalwork removed. And I think that's a point for discussion really between the patient and yourself. And whilst there is some evidence or some centers would definitely take the metalwork out routinely, others won't do it routinely. We went through a phase of removing all of these implants, thinking that we will achieve good movement in these joints because we're only bridging, but actually they're stiff as a rod essentially when you take the metalwork out. And metalwork removal, we know, carries a certain amount of risk and complication with it. So with the high end athletes or sports guys, I would have a lower threshold of removing metalwork. I don't know how others feel about it.
Let's take a vote.
Yeah.
Let's take a vote. Okay, Start with Sampat. Sampat, would you routinely remove bridging plates?
No, sir. I usually don't remove, but I tell the patient that sometimes it will break, and if they break, they will auto-stabilize. So I won't remove them.
Balwinder?
I don't remove them routinely. If they break, they become...
if they break and there is some prominence or there's some rubbing of the tendons, they don't move from it. What you're trying to tell me is like a syndesmotic screw. It breaks, but it doesn't move. What about you, Khairul? What do you do in Malaysia?
I don't remove them routinely, but if they do break, then I tell them that there are possibilities that some of these screws may migrate either proximally or distally. So those are some of the issues.
But let's look at this particular case. This particular case, he had a hyperflexion injury 1 year post-op. So that means there was significant movement at these joints, which, and there was also a stress on these metal plates, which was going on doing it. So does this kind of case make us rethink our philosophy? Because there is going to be a metal fatigue anyway.
I think why we should be doing more primary fusions. There has been some reports. If you are not happy removing the plates, why not fuse them? That's the question. So there have been some retrospective or randomized control trials and systematic reviews, which now tend to favor primary fusions for these kind of injuries, even for low intensity Lisfrancs.
We are in our last minute, but I want to show the next, no, not the next case, but the next slides, 2 slides before we are thrown out of this room. So this is what was done, and he went back to playing football. But what I want to talk about is this MRI. Could you tell us about this patient's MRI, which you did 6 months after removal of the metalwork, Jeet?
Yeah, so we're actually looking at it just as a point of interest, and also what really happens to Lisfranc ligament. Obviously, we reconstruct all these with metalwork outside of where the original injury is, essentially. So, taking the example of ACL, does ACL ever repair? Does Lisfranc ligament ever repair? So we're looking at patients at the moment who've had their metalwork removal done to see whether Lisfranc ligament ever comes back as a Lisfranc ligament. And so far, with preliminary results on a few, we're not seeing the ligamentous structure there. So it doesn't reconstruct back to or repair back to being a Lisfranc ligament. It's more of scar tissue, which stabilizes in that position, which is what I think most people would expect. And that's why metalwork kind of holds it in that position for it to just gum up, really.
But if it's scar tissue, should it not become painful over time?
Yeah, well,
I think we'll have to end up with this case. So we'll go on discussing this case only and not start the next one, because
yeah,
we've only got
Mandeep, can I ask one quick question? Because we got something from the audience.
Yes, Selene.
Jiten, this is for you. On the divergent Lisfranc case you showed, do you test for medial and intermediate cuneiform joint stability after the Lisfranc screw?
Yeah, so you basically stabilize the medial column connected to the middle column. Have I understood your question right?
So they're asking, once you put the Lisfranc screw in, is that when you test for the intercuneiform joint stability, or do you do it before you put the Lisfranc screw?
After.
Okay. All right.
Okay.
All
Anybody
right.
does it differently here? Thank you, Selene.
Thanks, Mandeep. Thanks, all of you guys. Great seeing you.
Thank you.
And,
Thanks very much.
Thank you.